A very warm welcome to this session on indirect annuloplasty for functional mitral regurgitation. So we have a fantastic panel here, I think, and you can learn a lot. So let's introduce the speakers. So my name is Nina Wunderlich. I'm from Germany. So we have Nathan Newton here next to me. He will help to run the session very smoothly. We have fantastic speakers with a lot of experience. We have Vlasis Ninos from Greece. We have Martin Svars from the Netherlands, and we have Mauricio Tamarasso from Switzerland, actually, Mauricio. Correct. So what are the learning objectives? I think one aspect is that we hear something about the latest data of the device, but maybe more interesting, we will focus on a couple of very specific questions. So for example, a specific scenario would be atrial functional mitral regurgitation, and another very interesting aspect is the treatment point of secondary mitral regurgitation. Are we maybe too late at this time point? And if you look at this graphic, so it gives you an impression that the sweet point where we should address a patient is maybe a little bit earlier than we address the patients at the moment. So I think this is something we should keep in mind for the entire session. So it will be my pleasure to start and introduce the first speaker, and this will be Vlasis. And Vlasis, you will speak about the EMPOWER trial. I think a very important trial which will provide us with very insightful data in the future.
Thank you, Nina. Dear colleagues, so the topic of my talk would be don't get stuck in habits, and when I'm talking about habits, I refer to the habits that we all have in treating heart failure. And the Carillon mitral contour system is a system that is introduced, as most of you know, because the device has been around for a long time, inside the coronary sinus. Is a low-profile device that is introduced by the IJ, internal jugular vein. It's 10 French. It doesn't require transeptal puncture or any additional anticoagulation. It doesn't even require conscious sedation sometimes. It can be done under local anesthesia. TE is not required. It is completely recapturable and removable, and it allows for future therapy. So the safety profile is established, and there's no need to change the medication. The rationale is to deploy it inside the coronary sinus in a pre-specified landing zone, proximal and distally. Once the distal anchor is deployed in the distal landing zone, then cinching start by pulling gradually the device and deploying the proximal anchor to a pre-specified location. And you can appreciate the foreshortening of the anteroposterior diameter of the mitral annulus, the pulling at the base of the heart, and of course the reduction of the perimetry of the coronary sinus. So what is our unmet clinical need? Clearly, heart failure is prevalent, and we're getting a lot better in treating that with medical therapy, but that is associated to a certain degree. It depends on the degree of mitral regurgitation, but the proportion can vary between 30 and 50% in various studies. And of course, there's a huge spectrum of disease that stems from the early disease with mild mitral regurgitation to the more advanced disease with advanced mitral regurgitation. We know that we have TEER therapies for severe MR, but what about early stages? We've become a lot better as a community treating that with addition of further medication, SGLT2s for example, but there's still a big unmet clinical need. So what do we know from the Carillon data so far? A few studies with over 450 patients have run over the previous year, starting back in 2007, Amadeus, Titan 1, Titan 2, the randomized trial with a double-blind sham control design, reduced FMR, and the ongoing studies, the CINCH FMR and the EMPOWER trial that we're going to talk about, with independent core lab assessment, all focusing to certain patient subjects. So either patients with mild to moderate FMR or patients with large ventricle. So you can see from these two papers that when a small number of patients have been evaluated, there was an improvement even when the mitral regurgitation was mild or moderate. There was an improvement in the 6-minute walk KCCQ index score. The FMR improved further, and we had improvement in New York Heart Association with a very acceptable 1-year survival. The same happened in this trial with big LVs. We saw that there was a reverse remodeling of the left ventricle with a decrease in the end diastolic volume, but by a significant amount, 25 cc's, and also end systolic volume, and similar improvement in the quality of life matrix. So that fueled the passion to design the EMPOWER trial, which is again a double-blind, sham-controlled, randomized trial aiming to recruit 300 patients in total with a pre-specified interim analysis at 150 patients. The primary point is a hierarchical endpoint focusing on win ratio between all-cause mortality, between the two arms in all-cause mortality, the need for alternative therapies such as heart transplant or LVAD, alternative therapies such as mitral intervention, surgical or percutaneous, and then of course heart failure hospitalization, KCCQ and 6-minute walk. It is very important to see that the enrollment criteria is actually very broad and it's very easy to recruit in this trial. All you need is patients in heart failure and NYHA class 2 to 4 on maximum tolerated GDMT, stable dose for 1 month. By definition, we don't want to have, it's a contraindication to have a CRT lead in the coronary sinus, and of course no other mitral valve repair devices. But all you have to do is reduce ejection fraction less than 50%, and diastolic diameter more than 57, and systolic less than 75, and at least some degree of mitral regurgitation. And of course it's all adjudicated by central core lab and review committee. So as a conclusion, EMPOWER trial is coming to answer the question whether we can actually meet this unmet clinical need and forget about all habits of sitting comfortably on these patients with stable heart failure and go a step further to remodel their left ventricle, allowing to enroll patients at an early process of the disease. Thank you very much for your attention.
Thank you, Vlasis. I would like to remind the people here that you can ask questions if you're too timid to come up and ask them, but the floor is open for 1 or 2 questions, if anybody has. And probably to get you around it, I will ask a poll to be shared, so you can interact on the poll session on your app. And so we'll pull in the first poll question about remodeling. And actually, I would like to ask you a question while the poll is coming up. So if you can see, interact there and ask, do you believe that ventricular and atrial remodeling are important for the patients and the course of heart failure? And Vlasis, what is remodeling when you clip a patient in COAPT?
Well, we have some data that shows that despite the amazing clinical improvement of this population, we do not see any reverse remodeling of the left ventricle. So the dimensions do not seem to reduce. We don't have any reduction of the volume, both end diastolic or end systolic. We have increased in the cardiac output because obviously the backward regards and volume from the mitral regurgitation is eliminated, but we do not see the signs of remodeling. So this is an unmet clinical need.
So I hope this is already the voting. What do you think? I mean, everybody thinks that remodeling is a very important factor. We are treating heart failure patients. So what would you consider is the piece of puzzle targeting the mitral regurgitation in this entire setting of treating heart failure patients?
Well, we clearly want to set the clock back, right? I mean, we know that heart failure is a continuous worsening syndrome and the ventricles dilate and patients get worse. So if we can somehow pull the tissue together and reduce the volume and increase the performance this way, that is expected to have a positive outcome on the patient. So there is a rationale to it, and the EMPOWER, it's all about trying to prove this concept in a meaningful clinical events.
So let us follow this idea. So if the EMPOWER trial will be positive, that means we see definite remodeling of the chambers. So how would this influence your daily practice?
Well, I think clearly there will be room for considering these patients earlier in their disease process for action, like for implanting, for example, a Carillon device. Right now, the guidelines are very clear. You continue with your GDMT, to go to the maximum tolerated dose. You can implant CRT if there is an indication for that. And then if you have severe mitral regurgitation following the COAPT criteria, you do TEER. What happens in between to this population with mild, moderate MR, big LVs, reduced ejection fraction? I think it will have a major impact to our daily practice, in my opinion.
So at the moment, EMPOWER data are not here at the moment. Maurizio, how is your daily practice? When do you consider, I mean, it's the only annuloplasty device which has CE mark at the moment. So what is, in your opinion, your experience, what is the place for such a device in the current scenario before we get data from EMPOWER?
I think the place is, let's say, independently from which the result will be from the trial. I think there is definitely a role for early treatment, because actually we will see later on, you do not impact on the valve anatomy that much, if any. So the footprint that is on the valve is minimal. So you can eventually counteract the maladaptive remodeling, reverting the process, or helping together with CRT and GMDT. And then you do not preclude any further treatment. So that's why I think this therapy, which is extremely safe, can be applied a bit earlier maybe than other therapy. And then obviously in atrial aFMR, where really you have as a pathophysiological mechanism for MR, mainly annular dilatation, you just go to correct what is causing from an anatomical standpoint, at least the mitral regurgitation. So I think also in this population, which is emerging, I think there is a big role for this annuloplasty device.
So to summarize it and to get an idea, so it's more a treatment of the heart failure than the mitral regurgitation, more in this direction.
At the end, it is secondary mitral regurgitation, secondary to heart failure. So you need to treat heart failure first, ideally, and then also mitral regurgitation. With this approach, you actually address both, but mainly, yeah.
So if you look at the trials, SGLT1 inhibitors, do you think they would have changed the result of the studies?
Well, clearly your comparator will change, your outcomes may change, but ultimately these are adjacent treatments. Of course, we all need to have an outcome which has statistical power, but these treatments are complementary to each other, and in the end of the day we have to prove the endpoint, but you can combine both. I mean, we've seen it with the MitraClip that you have a good result from a tear, and then you can increase the medication, so you help the patient twofold by doing the procedure. So I think this will be a concomitant.
I will be moderate about that, because there's not so much reliable data, and there's many limitations on the COAPT and the ReShape studies that are with lots of confounders in those trials. We've got a question from the floor. Is the implantation of CRT cable, CRT is implantable after you put in the Carillon?
Yes, we've done it, and actually you have a very nice marker there to find your coronary sinus, so it's even easier.
And dislodgement of CRT leads, coronary sinus leads, did you see that?
Not in our experience, but I think the device, you mean dislodgement of the Carillon device?
No, dislodgement of the pacemaker lead in the coronary sinus.
After the Carillon device?
After
we only did
device.
two patients in our practice, and we haven't had any issues, but I'm not aware of any data. So.
And anyway, now we are starting to stimulate the left bundle directly, so it is also changing in this field. Thank you very much.
Thank you.
We're going to go to the second speaker, and now we're going to talk. And it launched on the. And if it's not the ventricle, indirect annuloplasty in aFMR, which is a new disease. Martin, what do you think about that?
Good. Yeah, it's not a new disease, but I think we're just recognizing it finally. So let's talk about the Carillon, or indirect annuloplasty in aFMR patients. So these are my disclosures. So what we know, and it's already very nicely shown in the previous presentation, that Carillon is a proven therapy for patients with a secondary mitral valve regurgitation. So it has been shown to improve significantly the amount of mitral regurgitation. With this, we see an improvement in NIA class, but also, as shown before, a significant reduction in LV and LV remodeling. And with that, we see an improved quality of life with a 6-minute walk test, but also KCCQ significantly increasing. And if we look at secondary mitral valve regurgitation, we have actually two ways of looking at it. So we know there is a version where it's the dilated ventricle due to ventricular dysfunction, and this could be due to a myocardial infarction or a DCM or something like that. But more and more it's now being recognized that there's also a sort of atrial FMR with atrial fibrillation and HFpEF patient being the large group having this kind of pathology. Initially it was actually quite thought about this quite easily. There's just the annular dilatation, that's just it. deficits, and it's causing the mitral valve regurgitation. But we have now different causes, and we have the same effect, but the question is the treatment is going to be the same in these patients. So, but we now also have learned that there are newer findings. That's a new novelty we don't know about. So it's not only the annulus that is the problem, but also the hemodynamics in the annulus change, in the atrium change. But there is also lack of leaflet growth. Yeah, leaflet can grow on the posterior side, but also what we learned is that it's not only the annular dilatation, so the type 1 Carpentier, which more or less is 60% of these patients, but actually 40% of these patients have a sort of type 3B, where the posterior annulus point goes over the crest of the LV, and it becomes a very restricted posterior leaflet, which is causing. So it's a different mechanism, same disease. So if you look a little bit about the epidemiology of these patients, so around 20 to 30% of these patients have a moderate to severe MR are caused by an atrial FMR, and we see it a lot in patients with AF. And the longer the AF persists, the higher the chance there is that these patients will get the mitral regurgitation. And as said before, the HFpEF group is the other one, with around 50% of these patients are discharged with an aFMR out of the hospitals. So what are the risk factors? So age, we see it more in female patients, and again, long persistent atrial fibrillation, hypertension, and HFpEF patients. So, but if we look at the aFMR and the prognosis, and we can see on the left where aFMR is compared to the primary MR, we can see aFMR is not a benign disease. So we can see the prognosis of primary MR is quite okay, but if you look at the aFMR, there's a significant worsening in mortality and hospitalization for heart failure. If we compare it with the secondary ventricular MR, it's not as bad, but we can see the lines are quite close to each other. So again, aFMR is not a benign disease. So again, we have different mechanism, but the question is, if we're looking at treating this mechanism, do we all need the same approach? So, and of course with this, we go back to the guidelines. So if we look, and we already said it in 2019, it might need a different approach. There might be a different reasoning behind it. It makes sense to have a different approach to treat this aFMR, but up to now, there's not so much data on this. So what we already saw by Vlasios is very nicely how the Carillon works. So what the idea is that the coronary sign is in near the proximity of the annulus, and by cinching it, by putting in your device, you can reduce the AP diameter and start reverse remodeling in these kind of patients. And what we'll see when they are responded, we see a reduction in the perimeter, we see a reduction in the AP diameter, intercommercial distance, the area gets less. But over time also we see reverse remodeling, and over time we see less and less regurgitated volume over the valve. So what do we know a little bit about the Carillon in this kind of population? So again, there was not much data, and we only have small studies, but this study was checking if the aFMR patients and the FMR patients had the same comparable outcomes. And what they nicely showed that both had a similar reduction in echocardiographic parameters, but also the same amount of near-class improvement post-implant. And there was also a small study comparing TEER with aFMR, because as discussed before, with even in the co-op trial, we did not see reverse remodeling. And here again, a small study, but after 12 months, they saw significant LA reduction and significant LV reduction in the patient being treated with a Carillon device, which was not shown in the MitraClip device. So just the case from out of the practice from our patients. So this is nice, you can see it's a good ventricle patient, but a significantly enlarged left atrium, a typical kind of case for an aFMR. We can see there's significant mitral valve regurgitation from the full line of cooptation here. So I don't think there's a doubt about this. And nicely shown already before. So we put in the catheter to measure the length of the device, and based on the length we decide how much cinching we're going to achieve. So the distal anchor is going to be deployed. We cinch it, and we're going to place the proximal anchor. You can clearly see here the annulus before and how much reduction we can achieve by putting in the Carillon device. And these are already the post-procedural results. So this is in the cath lab. As said, it starts reverse remodeling. So sometimes in the cath lab, the MR reduction is not that impressive, but I think already looking at this page, you can see there's a significant reduction already in the MR, but also in the AP diameter here, and also looking at 3D en face, we can see a full line of cooptation leak, which actually goes down to a mild leak here. And if we look at the dimension measured, we can see a significant AP reduction, significantly decrease in vena contracta in the long axis and the intercommissural view. And again, it starts to remodel over time, and this is already after 3 months. You have the impression that there might already be some left atrial reduction, but again, it's clear to be seen that there is a significant reduction in mitral regurgitation in these patients. So to conclude, I think it's a different entity. So we have secondary MR, but it's a distinguishing different disease, the aFMR patient. So an aFMR is definitely not a benign disease. So we have seen that Carillon has proven his therapeutical value in FMR patients, and it shows in small study up to now promising results, reducing the same amount of MR and improvement of NIA class post-implant as compared to FMR patients, and it seems to induce atrial reverse remodeling. Thank you very much.
Thank you, Martin.
Yeah.
So as we can clearly see here, the new target and the target of this device, which is unique, is remodeling, which I remember, I will remind myself and yours, as I'm a heart failure specialist, that LV remodeling and secondary MR is a disease of the left ventricle, not of the valve. So that's a very interesting tool, which has, well, you have to take the data with caution because it's small samples, so it could be influenced by individuals. But do you think that is there a randomized trial being started are we thinking of a randomized trial?
I think there was the aFire trial was ongoing, but unfortunately stopped because of difficulty in enrollment. But I think, unfortunately, we still have to look in this population. We see it more and more, and like we said, 20 to 30% of the patients with a secondary MR have an aFMR. So we see it more and more, and the older the population gets, we will see more HFpEF patients, we'll see more atrial fibrillation patients. So I think we should be able to do a new study to look at these patients, because they deserve a little bit better than just some small studies here.
Thank you very much. I've got a question from the floor. After reverse remodeling and treating the cause of AMR, such as AFib ablation, potentially, is there a possibility to extract the device?
I wouldn't do that, but it's not possible. It will grow in, and I don't think you want to do. The coronary size is quite gentle and thin structure. If you look at an anatomy basis, I don't think you want to retract it. And in the other end, you want to prevent further dilatation or anything. And I think pushing like an annuloplasty from the surgeon, you're going to implant it. You're not going to get it out later on if you're happy with the results. So I would keep it in.
Martin, according to the guidelines, we are at the moment differentiating between patients with long-lasting atrial fibrillation and patients with HFpEF. I always have trouble with the separation, and my thoughts are, well, a lot of these patients occurring with atrial fibrillation might have a diastolic dysfunction already. So what are your thoughts on that?
No, I completely agree. There's a huge overlap in these patients, I think. Having HFpEF and atrial fibrillation, this is a sort of process ongoing with increased LA pressures, and a lot of these patients have atrial fibrillation. So it looks like there's a clear line and distinction between those, but there's a lot of overlap in these patients. So it's not so easy to really say, but it's a pattern. I think there's in these patients. And
maybe we could estimate that a patient with a real HFpEF situation, I mean, this is a heart failure patient on the other side. So this is a completely different story rather than having just a patient with long-lasting atrial fibrillation, because as soon as the ventricle is involved, the story is getting another one. Yeah. Any questions from the auditorium?
I have one question, please.
Oh, yeah.
It's about the procedure. Do you have the? We have maybe Flavio or Martin can reply the question. We have the risk to pinch the circumflex with this device, maybe, and how we can protect this.
Okay, maybe you as an intervention, I think we learned a lot over time, but...
we always implant the device having a control, can you hear me? Yeah. Having a control angiogram, and we look at the crossing between the circumflex and also the distal RCA, and we keep an eye. I mean, in theory, about 10% of the patients may have impingement depending on the anatomy, and we see it there and then. The good thing with the device is that it's fully retrievable. You can just take it out. But on a few occasions, by using some nitro inside the coronaries, we were able to relieve a spasm caused by the pulling, and it's fine. So it's totally safe. It can happen, and of course, that's a reason to abort the procedure.
But Vlasis, are there any parameters you address? You said you look at the fluoroscopy with the angiography. Do you look at something specifically, for example, the angulation between the annulus and the circumflex? So what is something you can give the people here if they go home, some parameters to look at?
We look at it during the procedure. I mean, in the past, there were efforts made to do a CT coronary angiography and try to predict. It's not always predictable because they come at a different plane, and sometimes you see the crossing and there's no cinching, no pinching on the circumflex. Other times there is, and you wouldn't expect it, but it's not very common these days. It's in the order, I would say, 10%. I mean, in our practice, we haven't seen it. We've been lucky. I mean, we only had one patient with some pinching of the circumflex, and we just gave nitro and went away. So it's something you see there and then.
We've got questions tumbling down, so thank you very much for the interaction. So further word on the safety of the Carillon device. What are the risks of sinus thrombosis, myocardial infarction, and device migration?
Extremely rare. We choose the size of the device on the table based on the measurements we do on fluoroscopy. We oversize the anchors, and we pull the device from the distal to the proximal end in a pre-specified distance that we choose. Device migration and uncoupling, I haven't seen. Thrombosis is very rare because these are open anchors, so that you don't block the flow at all. So extremely rare. It's very safe.
And I've got another question for Martin. Does the device cause any cautions or difficulty using diagnostic catheters in the coronary sinus for ablation procedure?
No, as Ninos very nicely said, it's an open structure. Of course, everything you might need a little bit more maneuvers around, but it's actually a quite open device. So getting in a pacemaker later on or anything, that's actually maybe a little bit more difficult without a device, but I think it's quite easy to place something in the coronary sinus afterwards.
Great, thank you.
Martin, I would like to dig a little bit deeper into the topic of remodeling. I mean, it's very obvious if you reduce the backflow, you'll get a remodeling of the left atrium. Left ventricle might come a little bit later, so we don't have that big impact because usually you have some residual mitral regurgitation. So what is the time frame when can you expect remodeling? Because real remodeling, we have a diastolic remodeling. The diastolic volume is getting smaller, so this is something we can see immediately. Yeah. But we are waiting for the structural remodeling, which is maybe the more impactful parameter for the patients on the long term. So how long do we have to wait to see this?
A very good question, Nina. Indeed, we see first of all some functional remodeling or anything, and then the structural remodeling. Actually what we have seen, the difference in timing is quite different in all these patients. I think every echo, sometimes you see this process ongoing actually. So it will, after 3 months, I think you will see the first. After 6 months, you will see even better. And I think it's a process you reduce the tension on the wall, and then everything keeps on going. But exact timing, I think after 6 months or something like that, you will see most of the effect, I think, in most of the patients. But it seems to continue over and over afterwards.
Well, thank you, Martin. I think we can move to the next speaker. And now we have so much devices, Nina. Now the question is, where do I start? Do I put the sugar first, the flour first, the eggs, the chocolate? So that's where Maurizio comes in and tells us why you should start with indirect annuloplasty, my Carillon and remodeling experience.
Thank you so much. And actually, we don't have data, so there is not a precise algorithm when to start. I think it's important to put the patient and his anatomy in the middle, and then try to tailor the synergy of the different approach to that specific situation. But I will try to bring you some argument why it makes sense to start with indirect annuloplasty. We have been discussing a lot which are the mechanisms leading to reverse remodeling by the Carillon device. Obviously, we have some acute changes, which are mostly due to the reduction of the anterolateral diameter of the mitral valve due to the CINCH of the coronary sinus, that as a consequence reduce the coaptation gap between the leaflet as well the mitral regurgitation, and obviously reducing mitral regurgitation as well in the chronic run will have an impact on reverse remodeling. So we have a mechanical effect, and then we have a secondary effect due to the reduction of the MR. And both reduction of MR and reverse remodeling translate, we have seen several data, to clinical improvement and hopefully also, in prognostic benefit. Fewer hospitalization for heart failure and improved survival. I'm sure everyone in the room knows how the device works, but I really like to show these 3 small clips to show how much you can remodel the mitral valve using the contiguity of a different structure, which is the coronary sinus. This is why we call it indirect. And I want to point out that it is indirect because actually you don't touch the valve itself. And this is why, from a technical standpoint and interventional standpoint, if you start from annuloplasty, then you don't close the door for any other option. I will show you a case later on where we did also CRT implantation. We've been discussing a lot. So you do not preclude resynchronization. You do not preclude TEER. You do not preclude TMVR. You can still do everything. So if you start with this approach, you can actually eventually already delay other treatment or actually save it if you already get clinical benefit of enough remodeling with starting with the coronary sinus annuloplasty. There are not, let's say, 100% recognized definition of cardiac remodeling. I think it's important for the people who are not really inside the heart failure community to distinguish between what we say maladaptive remodeling, which is actually what is the consequence of heart failure, which is the ventricle which is becoming larger. There are some aspects that are associated with higher chance of cardiac maladaptive remodeling, which are the etiology of the MR, the duration of the symptoms. The lower is the F, the faster will the ventricle remodel. And then when we talk about remodeling after the therapy, we refer to reverse remodeling. Reverse remodeling is what is actually bringing back the heart to closer to a normal position. And there are, again, different definitions which are in evolution. It's probably not only a matter of dimension and diastolic and diastolic dimension or volume. There is probably much more. You have seen, if you look at the definition of heart failure, just to give you an example that has been provided over the last few years, you see how much this field is evolving and becoming more complex. The more we study this topic, the more we see that there are really different subgroup of patients, and one single definition of reverse remodeling probably would not apply to all the patients. So we should probably learn a little bit more which amount of remodeling we should target for each kind of this specific group. Carillon showed reverse remodeling in different subgroup of patients. We have been discussing already this data, so we can definitely reduce the dimension of the ventricle and of the atrium, partially due to the acute effect, so the mechanical effect, partially to the secondary effect, which is related to the reduction of the mitral regurgitation. And this has been observed in different clinical aspects. So the remodeling associated with Carillon is associated not only to reduction of dimension, it's also associated with reduction of MR and improvement in NIA class symptoms and reduction in heart failure hospitalization. So actually, there are not one specific subgroup of patients where we could not expect a clinical benefit. So there is reduction of the antero-posterior diameter. So again, this is the acute effect. There is reduction of the intercommissural dimension as well. So we reduce the annulus not only in the antero-posterior dimension, but also in the intercommissural dimension. And we reduce, as Martin showed us, also the left atrial volume. I show you one example of how the synergy of different therapy can help our patient with secondary mitral regurgitation. And I show you why in the field of mitral treatment, reverse remodeling is extremely important, and annular remodeling as well. There is now this new parameter. The more we talk about atrially driven mitral regurgitation, the more this parameter is becoming something that we have to evaluate, which is actually the leaflet to annulus index. It's really easy. Basically, you measure the length of your leaflet, and you do the sum of anterior and posterior mitral leaflet, and then you relate them to the anteroposterior diameter. And if this is obviously, if the annulus is larger than the sum of the anterior and posterior mitral leaflet, if we do not remodel the annulus, we will have recurrence of mitral regurgitation and progression of annular dilation. And this translates then in worse outcome. So if you have a low leaflet to annulus index, so basically if the annulus is too large with regard to the length of the leaflet, we have increased risk of recurrent MR and suboptimal result after transcatheter edge-to-edge repair. And we don't pay too much attention to this. I mean, I tend to exclude patients with too large annulus from TEER, but it's something that is not stressed enough. Obviously, we cannot change the length of the leaflet. What we can change is the length of the anteroposterior diameter by remodeling the annulus. And here I show you one case, which is a patient with advanced heart failure, let's say mixed, there is atrial component, ventricular component. This is obviously mainly ventricular driven functional mitral regurgitation, severe. Obviously, the patient was under guideline treated medical therapy, so let's say the patient was optimized from a medical drug standpoint, and you see the leaflet to annulus index is 0.9. So there was a really enlarged annulus, and the leaflet were relatively short compared to this anteroposterior diameter. You see how the annulus is deformed. The leakage is central, so mainly in A2P2, but it extends also to the wall line of coaptation. You really see that the annulus seems larger anteroposteriorly than intercommissurally, which is not normal. So really dilated and deformed annulus. So if you want to treat this patient and give him a better chance of clinical improvement, you should probably fix not only the mitral regurgitation, but you should try to fix and to help the medication to fix the reverse remodeling. In this case, and I'm obviously provocative, we started with TEER. This is one of the first cases that we did. So we didn't have so many data at the time to show that you can actually start from annuloplasty and maybe just stop. So we started with TEER, but we had the impression from the real beginning that TEER would have not been enough, even if we were able to achieve a good result in terms of MR reduction. Basically really mild MR, but you see, if you measure after TEER, the leaflet to annulus index is still less than 1. The leaflet didn't change the length. There is a minimal annular effect, but really minimal. You see, the anteroposterior was 47 before, it is 47 also now, so not that much change. So it is true that you may have some indirect effect on annulus, but it's not really marked. And then what we did, we just waited 1 month, and then we did annuloplasty. You see how much cinching we were able to achieve in this specific case. And this is what happened acutely. So acutely, we were able to bring this leaflet to annular index to more than 1, which is actually what is changing the risk of recurrence MR and then increase hospitalization in this specific patient. So it really improved anteroposterior and intercommissural dimension, which correlate with obviously a bigger than 1 leaflet to annulus index. You may see immediately, this is the annulus at the beginning and this is the annulus now. You see that it has just a different shape. This is a more physiological annulus. And then, in order to improve further his prognosis, there was an indication to do resynchronization, and as we already discussed, it is quite straightforward to put a lead in the coronary sinus. So you can do resynchronization after Carillon. It's not a contraindication. You should not be scared of doing this because the risk is minimal. So in conclusion, indirect annuloplasty is associated with annular and ventricular remodeling. Annular remodeling is fundamental, if not the most important part of mitral treatment in patients with heart failure, and it is definitely associated with improved outcome. And then we are learning how to use this different intervention in a synergic way. They are complementary therapy. For many years we have been starting with leaflet therapy when probably the leaflet were not the main problem. So why don't you start with annuloplasty first in a case like this, and then eventually maybe the outcome will be so that TEER will even not need it eventually at the follow-up. Thank you for the attention.
Maurizio, this was a wonderful case, and this would be my first question and impression. So if you look at your case and asking yourself, after hearing everything from you, would you change the order of your procedures? Maybe CRT first, then mitral annuloplasty? I think, according to what we heard, this would make a lot of sense.
Well, CRT cannot be before annuloplasty.
Yeah, if you think about it, but yeah, okay. If you think about annuloplasty, but annuloplasty would come first. If you would reorder.
Definitely yes. I mean, there are probably some patients where annuloplasty first is the best. There are probably patients when it's probably easier to do something different. We don't have a precise flow chart, but definitely if you do annuloplasty first, you reduce the diameter and you may improve the mitral regurgitation as much as it is needed to improve the clinical outcome for the patient. So maybe you don't need to do further treatment on the valve, or you can make the grasping of the leaflet easier. There are some patients that are really advanced. We may discuss if they eventually are candidate for interventional therapy at all, but if the gap is big, it's difficult to grasp the leaflet. If you reduce with annuloplasty the antero-posterior diameter, then you make a procedure which is challenging easier. So yes, absolutely.
Blasis has a question.
That was an excellent presentation, and I like the fact that Carillon device leaves all options open for the mitral valve. We have seen patients now with the TEER procedures being, we're doing more and more of those. We're left with a device in the middle of the valve, and you as a surgeon know much better that actually taking these devices out, either percutaneously or surgically, you damage the leaflets, and you have no options left afterwards. So I think this is a very useful concept.
We've got a question from the floor. Is concomitant indirect annuloplasty an MTR procedure that we are going to see more and more in the future?
Obviously, from when the surgeon operates on the mitral valve, they do everything in one stage. So they do annuloplasty, they do leaflet repair. So from a pathophysiological and philosophical standpoint, it would make sense to do both together. But I think with transcatheter, you have the opportunity to stage the procedure and to see what happens after the first one. So I think starting with the one that has less impact on the anatomy, like annuloplasty, makes sense and give you the chance to see what happened to the heart and to the ventricle and to the mitral regurgitation, and eventually to do the second stage as the TEER. So I don't think concomitant will have a super future, but who knows? I mean, we would need data.
Nathan, actually, you have the opportunity to have a heart failure specialist, so I have a question for you. Because, as we know, a lot of patients undergoing interventions are not optimally medically treatable. So, and we learned, for example, for a TEER procedure that it's possible to get a better up-titration of medication after the procedure. Did you see something like this with the annuloplasty devices?
Well, that's an excellent question, and actually that's one of the questions that EMPOWER trial is going to answer. The EMPOWER trial is the only trial that actually asks the question of intervening earlier. The Reshape HF COAPT don't answer this question at all. The question is, and even though they're trying to say it is, you have to intervene earlier, but they have no data to prove that. And EMPOWER will bring that, and will also ask this interesting question of devices using as a jumping rod for the medical therapy. So that's a very interesting question, and actually we could ask the people here. Can you pull up the poll for the last question on remodeling and MR, because that's. So I'll ask you to go on your app and vote before we end. And of course, what I, as a heart failure specialist, HF drugs has to be personalized. Diuretics have to be used properly, and we don't, in all those sessions that we are here, we don't hear about that too much. We're talking about devices, which is normal. So yeah, you have to remind yourself that what has a true impact is all the combinations of the therapies personalized to the patient's benefit in terms of quality of life and survival. So let's come on, please go and answer the question. What do you consider more important for the patients, MR reduction or remodeling? So here is we are gonna see what's the answer. Oh, it is moving as we speak. So we see that remodeling is a real important target, and probably the most important in heart failure patients, and all the procedures and treatments that have an effect on outcomes usually have an effect on ejection fraction and volumes, which are the indices that we see in the HF drugs trials.
So unfortunately, the time is going to run. And Nathan, it's up to you to summarize. What should we get out of here of the session and to conclude the session?
Well, thank you very much, Nina. Thank you to all our speakers. As I've just mentioned, we see that the Carillon device is a safe solution that allows you to impact directly not just the mitral valve, but the first target is remodeling, LV remodeling, and also LA remodeling. There's currently real solid methodological trials ongoing, and we are really impatient to finish the inclusions for the EMPOWER trial and have the results. And the future is based on, well, when you go in Germany, you get your heart is put of steel nowadays. It's less the case in other countries, but still, we have to find new therapies and combinations, and that's the next question with all those devices piling up, and that's the question for the future, and you should also participate in those trials to improve our knowledge on that. Thank you very much.